Head of Health Empowerment and Health Rights Unit at Faculty of Medicine at King Abdulaziz University. She is the CEO and founder and board member of the Sheikh Mohammed Hussein Al Amoudi Center of Excellence in Breast Cancer. She is also a consultant and a professor of obstetric and gynecology at College of Medicine, King Abdulaziz University, and an ex-vice dean of College of Medicine and Allied Science. She is also an ex-member of the Board of Directors, Union for International Cancer Control in Geneva. She is an ex-chairwoman of the Scientific Chair for Breast Cancer Research. In March 2007, she was awarded the first International Women of Courage Award from the US government in Washington in recognition of her work to break the silence and spread awareness about breast cancer in the Middle East. In May 2017, also she was awarded the Prince Naif Award for the Distinguished Women for her work in empowering women in breast cancer and health rights, particularly those with special needs, the deaf and mute. Also, she has a lot of publications. She's the author of Memories of a Saudi Woman, The Empowerment of Girls, and a series of 3 books on cancer patients' rights. Please welcome Professor Sami Al Amoudi.
Assalamu alaikum jami'an. Thank you, Mr. Chairwoman, and thank you for the kind invitation. I'm not a radiologist, but my work integrated and intersect with your work, and I'm honored to have today a session and to share with you cancer patient rights in Saudi Arabia. Being a cancer survivor myself twice, I've recognized that even for me as a patient, as a physician, when I got breast cancer, I discovered a new life. I discovered a new track in my career, which is health rights for cancer patients. Many people are not aware of the health rights of cancer patients in our country, and I think that this is one aspect of management that is essential for the management of cancer patients. Why now? What is the importance of this? For those who are non-Saudi, Saudi Arabia now in a stage of transformation in health rights, culture, and woman empowerment. It's not like before. So this is a royal decree from the king himself that is directed to all those involved in health rights and all the universities or the ministries to spread the knowledge about rights of women and empowerment of women. And this is the royal decree, which is, the number is 33322. I always keep telling my students, keep this number, remember this number like your name, because this is the historical decree that have been issued recently in 2017 and talking about this new culture, which is health rights and rights in general. Now, if you go back to the basic law, many people, there's a misconception that rights in Saudi Arabia, there is no rights, especially and particularly for women, which is not true. And the basic law of Saudi Arabia, even for us as Saudis, sometimes we are not aware of that. In Saudi Arabia, the basic law states in 2, what they call it, materials or bunud in that basic law, that healthcare is right for every citizen, not only for sickness, but as well for those who are elderly, who have special needs, etc. Recently, in 2006, it's not recently, but in 2006, the Minister of Health have issued the patient bills of rights. Not only that, Saudi Arabia now is evolving and it's part of the global community. And this is why the Saudi Arabia have joined many treaties, one of them, the CEDAW, I'm sure maybe you know about it, and the health part of it. And in 2015 as well, Saudi Arabia joined the Sustainable Global Development. This is a treaty from the United Nations, and Saudi Arabia joined 2015. All of these, they talk about rights, health rights in particular, and above all that is the Saudi vision. Every Saudi now, we know about Al-Ru'ya and Saudi vision, and one core in that is health empowerment and to have a good standard of health. Why are patients' rights important? I've graduated in 1981 from Faculty of Medicine at King Abdulaziz University. You can calculate how old I am from that date. But my generation, we have never talked about rights. We've never talked about women's rights, health rights. It was not recognized at that time, not even in the teaching curriculum. Nowadays, things are different. And even the community itself, if you are a Saudi, I'm 100%, you in your clinic, you with your student, you recognize the changes that are happening among the young generation. They recognize what is health rights. Woman will discuss her rights in your clinic. So you have to be careful because now the awareness of the rights is very high. And this is why it's one way, if you recognize the health rights, one way to protect you against any medical legal problem. Not only that, but there are few of the health rights that are essential and you have to be aware of so that you don't have problem, and this will build the trust between you and your patients. Now, for cancer patients in particular, sometimes, like in any culture, there is still misconception, ignorance, negligence, whatever you call it, among us, we as healthcare providers. I'm sure you face this, male and female, in your clinic. When patient comes for breast cancer or any kind of cancer, when we take the biopsy, you will find that the result will be reported to the husband, to the father, to the brother, before they report it to the lady herself. They will call the husband and ask him to come to the hospital, especially in the private sector, and they will tell him, this is the result, it's cancer, and you could inform your mother, your wife, sister, whatever. And unfortunately, this is in a study we have done in our Faculty of Medicine among our students. We found that this right of having disclosure or hiding the information, all these, there is a lot of misconception even among the medical students, and this is extremely serious. Like the patient tried to hide information from her or his family. 67% of the studied group, they said they don't have the right. So there is misconception and rights are not fully understood in our culture. I'm talking about now, but definitely now is much better than before. Who have the right to consent? Another big issue in Saudi Arabia. Now, for any procedure, diagnostic, invasive, for you as radiologist, for surgery as well, mastectomy, for us as obstetricians, cesarean section, etc., etc. Many people, many doctors, many healthcare providers, they are not aware and they think that the guardianship system is still like it was years before. They will insist on having the signature and the consent and the approval of the husband. And this is a very serious mistake because this is very serious. It will be reflected on morbidity and mortalities. In one of our studies, we found that still until this minute, 10 to 30% in different hospitals, they are consented by the male guardian. Now, what are the rules in Saudi Arabia? Even for us as healthcare providers, some of us are not aware that since 1984, the هيئة كبار العلماء scholarship declaration that the adult sounded mind capable woman is the only one who have the right to sign for any invasive procedure, whether radiology or surgery. Nobody is allowed. This is since 1984. Somebody might ask, this is our say, okay, that was in the 84, it's different now. It's not different. Until this minute, I can assure you, and if I ask you, you will have experience like we do in obstetric. Until this minute, while I'm standing here, you will find a lady in labor or a lady coming for mastectomy, and the doctors, they will say, where is the husband? Where is the signature of the husband? Because of either they are ignorance about the rules, or they are not aware of it, or they don't agree with this, and they don't agree with empowering the lady. And I keep saying, it's not because it's just empowering and we are empowering women. No, it's because of the morbidities and the mortalities. This is why the Ministry of Health, the system, the rules, and the regulation in Saudi Arabia, it's in the decision is in the hand of the woman. Like in our specialty or in obstetric, I cannot wait for the husband. Suppose the husband is outside of the country, or I cannot reach the husband. Same thing for you, for the mastectomy, and we had cases where the patient will refuse chemotherapy or refuse intervention or refuse surgery, and the lady will come back with metastasis, and this will contribute to mortality. So please, the rules are very clear. The consent, the approval is taken from the woman herself. Now, these are the Ministry of Health rules and regulation, and this is اللائحة التنفيذية. And in Islamic law, as I said, the scholarship, fatwa, this is since 1984. Now, genetic counseling. When I got breast cancer, I was diagnosed in 2006, then I had breast cancer in 2015. Being a doctor, it was expected that I will ask about the genetic risk because I have a daughter. In 2006, she was 9 years old when I got breast cancer. And the first question which I asked, is she going to have, or is she susceptible to have breast cancer like I did? Nowadays, the awareness is increasing, and many young ladies, they will come to me and to every clinic of breast cancer or surgeon or oncologist, and they will ask about the risk, and especially after Angelina Jolie. You remember Angelina Jolie? Some of you, I'm sure they know her. She had a strong history of family history of breast cancer. Her mother and her auntie and one of her relatives had ovarian. And we know that there is a relation between the two. Because of the empowerment, because of the knowledge, because she knows the risk, she was brave and took the decision of having double mastectomy. Now, when we counsel our patient, I always tell them, before you do the genetic test, you have to understand what does it mean and what you have to do if it turns out to be positive. If you are willing to have the mastectomy, go ahead and do the genetic test. If you are not, no need that you know that, well, the risk is about 85% and you are not going to do anything. So the option, if the test came positive, should be clear to her, and this is the right of the patient. Right of pregnant cancer patient, this is a very big dilemma to us as obstetricians because we have rights of the mother, we have rights of the fetus, we have ethical issues, we have Islamic rules. So this is why it's not a decision for one person. We have committees in each hospital. We have a lot of people from different specialties that will interfere, and we will decide whether to go ahead with the treatment or termination. People think that termination is forbidden totally in Islam. This is not true. Islam, I always say, is a beautiful religious, and it goes by al-mantiq. I don't know what's the word in English. Yes, thank you. So if there is a risk to the mother, or if she is going to have chemotherapy and if she is early in pregnancy, there is a window for termination in these cases. And it's a teamwork after all. Pain management. One of the things that I keep telling my doctors and my son, who is a doctor, and my daughter, who is a medical student, please, if I reach that stage, if I come in a terminal case, which could happen, subhanallah, please feel free in using pain management, because there's a big study from the WHO showed that Gulf region, which are rich countries, they are the least one in consumption of morphine and other pain management drugs. Why? Because we misunderstand Islam. No, don't give him, he will be addicted. No, don't give him, this will, the patient, al-ajr wa thawab. This is a wrong idea and a wrong conception, because everybody has the right to die in peace. Everybody has the right to have these whatever drugs for pain management, and this is one of the rights of cancer patients. Palliative care and DNR, these are a very sensitive issue, and we have rules and regulations, and we go back to the people who are expert in this. If we are going to write on the file, do not resuscitate. And there are fatwas regarding this. Of course, the right of the patient, if he is still early, to be counseled, and the family to be counseled if he agrees on that. One of the things which are extremely important, and still, unfortunately, the law in Saudi Arabia is not supporting cancer patients, is the right at work. I will tell you a story. When I got breast cancer in 2006, I wanted to go back to the university because I've resigned before that for family issue. Then they said, okay, in my department, it's okay, we have a space and we know her and we would like to have her back. And between brackets, but she's a cancer patient. The president of the university, and I owe this to him, he said, I did not ask you whether she is a cancer patient or no. Everybody knows she is a cancer patient. And I did not recognize at that time that they don't have the right to write this. They don't have the right to discriminate against me just because I'm a cancer patient. They don't have the right to end the work or promote somebody or not promote somebody just because he is a cancer patient. Even a medical report, they don't have the right to ask your physician to give them a report about your case unless he approves of that. So please, we have to empower ourselves with our rights. Last thing, which is an issue nowadays coming to the front because of the advancement in the treatment of fertility for us as gynecologists, the IVF and the assisted reproductive techniques, fertility and infertility rights. When a patient is diagnosed with cancer, doctors think that the priority is to treat her. The priority is to save her life. In Saudi Arabia, the young generation, they I think the percentage is around 60 to 70%. Not only that, because of the advancement in the treatment of cancer, and I'm sure you know that, we are seeing more and more young patients with different kinds of cancer, not only the breast. And fertility is a right for them. What happens? They give them the treatment, whether chemotherapy or radiation, and after that they will come to us and say, well, I want to get pregnant. We will tell her that the chemotherapy affected your ovaries. She will say, nobody talked to me about that. Nowadays, this is a medico-legal problem. If the patient is aware, she should sue that doctors because she should be counseled before we start the chemotherapy because there are options. وفتوى هيئة كبار العلماء recently they approved of not only the fertilization, the freezing of the oocyte, freezing of the embryos so that they could be used later after she finished her treatment. And okay, this is the last slide just to show you what does I mean or what do we mean by empowerment, health empowerment. If you have the knowledge, if you know your rights, it will make a difference in your life. This is the story of Moza. Her name is Moza min al-Imarat, from Emirates. This young lady, she had cancer when she was 9 years old. Because her mother is empowered with knowledge, she went to United States. They told her about the technique of having transposition and taking sample from the ovary. There are certain techniques to preserve the tissue of the ovaries. After the chemotherapy, they started to have another technique to put the ovary and to harvest the ovary, the oocyte. And later on, she started to menstruate, so they know that she's doing well. She got married at the age of 17. They used that frozen oocyte. They put it, they fertilized that one. She got pregnant, and it was published, and it was in the BBC News and everywhere. Of course, this picture, I don't have the right to put the picture, but it was in the public and in the BBC. And this is the empowerment. This is what we need to know about rights of patient in every aspect, and especially cancer patient for fertility and for other health rights. Thank you so much, and that's all about health rights.
Our next speaker for this session is Dr. Nuha Khomeyes. She's an associate professor at Al Faisal University and consultant radiologist at King Faisal Specialist Hospital in Riyadh, Saudi Arabia, where she serves as Director of Women's Imaging and Women's Imaging Fellowship Program Chair. She is the Chair of Radiology Committee for Morbidity and Mortality at her institute as well. She completed her radiology residency in 2005 at King Faisal Specialist Hospital in Riyadh, where she went on afterwards to do a clinical fellowship in breast imaging at the University of British Columbia and University of Toronto. She also has a medical education degree and research fellowship at the University of Toronto. She is currently a student at the Frankfurt School of Finance and Management, obtaining her MBA in International Healthcare Management. She has a very interesting hot topic for us this morning titled Contrast Enhanced Spectral Mammography, Innovative Tool in Breast Imaging. With that, I ask you to give your full attention to Dr. Nuha Khomeyes and help me in welcoming her to the stage.
Thank you very much. And I would like to thank the organizers and my colleagues and the moderators for this session. And I would also like to acknowledge my previous speakers for their great introduction that actually made my life much easier, including the last topic by Prof. Samia. So would just like to share some stories with what we do in breast cancer division at the King Abdullah Center for Oncology Disease in Riyadh, Saudi Arabia. So We are quite struggling with the local management for breast cancer, and for this reason, we struggle a lot to get patients doing additional functional imaging, especially when it comes to MRI. So in the coming 20 minutes, I will shed some lights on the current breast imaging limitations that we're facing, and how did contrast-enhanced mammography help us in local assessment of disease. What is value in clinical practice, and what are the advantages and limitations, and what's the future for contrast-enhanced. So as what was nicely illustrated in the previous talks, we're struggling with some limitations, and these are mainly related to breast density, overlapping breast parenchyma, the operated breast, like what we have heard from Prof. Asma, the breast implant, and the technical challenges. Some of them can be related either due to malpositioning or retroareolar region. That is quite challenging sometimes. But we all have to acknowledge the existing role for digital mammography as a screening modality. It's a cost-effective test, as we know, with acceptable radiation dose and proven outcome, especially in the screening setting. This is kind of echoing the same issue with breast parenchymal density. As you can see here, the breast pattern, the heterogeneously dense and the extremely dense breast parenchyma are the nightmares of a breast radiologist. We all know, but from the literature, we have lots of data supporting the challenges, that it is the most difficult mammogram to interpret. It has the highest interval recall rates and the highest interval cancers detected, and it has the lowest sensitivity with the lowest positive predictive value. The sensitivity for mammography in a dense breast goes down to 48%. Tomosynthesis is a better mammogram. It did help us to get rid of the overlapping parenchyma simply by projecting the lesions or the area of suspicion off the overlapping breast tissue. It is well known in the diagnostic setting, but in screening, it's coming more and more to the field of screening mammography, and the main advantages for this is that it did decrease the recall rate, so we don't really need to call the patients as often as we used to for spot compression views or magnifications. And it did improve the cancer detection rate with improved sensitivity, specificity, and positive predictive value. But it's a better mammogram is not the solution. And here is the story. This is a lady who was referred to our center in the one-stop clinic that we usually hold, in addition to our colleagues, the oncology, breast surgeon, and all this happens in one day, that is a Sunday. So this patient was diagnosed at an outside institution with a malignancy in the right breast. It is extremely difficult to see it, but I can point to you that this is the area here on the 2D mammogram. Focused images, here is the image on tomosynthesis, and I hope you can appreciate the architectural distortion around it. This is the 2D image. Again, that's a zoomed image. You can hardly appreciate anything, maybe a little bit of spicules projecting at the posterior fat parenchymal interface, and there is nearly nothing seen on the standard 2D image. Here is the ultrasound that shows the irregular spiculated lesion at the upper central breast, mid to posterior third, that correspond to the mammo finding. So based on that, we recommended MRI, but we couldn't get it done within the 4 days. So we had to go to the tumor board, discuss it with the surgeon, and put the recommendations. Unfortunately, because we didn't see anything in the initial ultrasound, the surgeon was really convinced that this is just a unifocal disease. But luckily enough, I was saved by my rad path correlation when I did the biopsy, and I said full staging with breast MRI is recommended. Then a week later, I was called by the radiation oncologist saying, Noha, I see your note recommending MRI. Do you still need the MRI? I said, sorry, she has a dense breast. He said, but she's in the OR now. She's the next case. I said, please reschedule. So the case was rescheduled, and we get the MRI. And here we can see the index lesion at the 12:30 o'clock location, exactly like this one. But in addition to this, we see another lesion in the retroareolar region or close to the nipple. So the patient was called back. We did a targeted ultrasound that shows the retroareolar irregular hypervascular nodule. And in retrospect, we felt that it's probably related to some subtle distortion noted at this area. So now we did the biopsy, and now it's multicentric disease. Now, is this the end? Unfortunately, no. Her MRI also showed an irregular nodule enhancing in the inner aspect of the contralateral breast. And I'm showing you the first look ultrasound, and here is the second look ultrasound, a little bit more focused on the area. This is exactly the same area, but it was initially misinterpreted as a probable complicated cyst. So we did look at it closely now, and it's rounded with some ductal extension. So we did vacuum-assisted biopsy for this, and it came out as invasive lobular cancer. So now we have saved the patient 2 surgeries at least. For the challenges that we're facing, as I have discussed before, is the breast density. Tomosynthesis is a better mammo, but it's not the solution. The reading time is much longer. The radiation dose is there. The storage in terms of packs and also the training is an issue. So we really need a functional study, and for this, our best friend is usually MRI, but the cost is higher. The availability and access is a challenge. The technique, you really need to strive to improve your diagnostic MR protocol. And then patient anxiety, claustrophobia is also another challenge. And then in the private sector, reimbursement is another thing to think about. So, contrast-enhanced mammogram was introduced to serve the same indications of breast MRI. So we use it now for the preoperative staging, equivocal finding, operated breast, evaluation of nipple discharge, response to neoadjuvant chemotherapy, and the last in the list in screening. So it is usually done over at least 7 minutes time, in which an iodinated contrast medium is injected. We use Visipic at my institution. We inject about 1.5 ml per kg at the power injector with a rate of 3 cc per second with a maximum volume of 120 cc. Now, in this illustration, you see that the imaging has to be performed over 5 minutes, and you can start either with the right side or preferably with the affected side. And then you move on, and if you have some time and you have picked something that you're not quite sure about, and it's not yet 7 minutes, you can still add in an additional image to simulate the kinetic pattern that we use for MRI. So it's usually acquired as low energy. This is our friend, the 2D mammogram at a lower energy technique. And then the higher energy is usually white. It's not informative, but we get at the end the low energy and the recombined image, which is simply a subtracted image in your workstation. So in this protocol, and this is our preferred protocol, is that we start with the side of complaint first. The technique, again, it goes around the K edge of iodine, and we have to use the low energy below and a little bit higher so we can acquire these 2 images, and then we perform the subtractions. And then we look at the recombined image. But as I have said, it has 3 main parties: patients, nursing, and equipment. So you have to think and consider whether you have an upgradable unit if you want to install or introduce contrast enhanced. These are the indications, as I said, and a few case examples. So this is a case of a screen-detected breast cancer in the right side. You can see the post-biopsy clip. I hope it's here in the upper inner quadrant. And the clip is inside. In the contralateral side, you see the enhancing irregular lesion, but there is also a faintly enhancing nodule in the left breast. So this was subjected to core needle biopsy, and it was fibroadenoma. And I hope you can appreciate the difference in the pattern of enhancement and margin of these masses. So this is one of the criteria that we currently use to evaluate contrast enhanced, because literally, at the moment, we don't have any dedicated lexicon to report contrast enhanced, and we're following the MR criteria. Here is a chance for this patient when we had an additional point added, so you can appreciate the progressive enhancement for this mass in favor of a benign finding of fibroadenoma. Another case example, here is a case that was diagnosed with invasive ductal carcinoma of the right breast, but we also see some suspicious irregular focal asymmetry is noted posteriorly. And I hope you can appreciate this tiny asymmetry noted in the contralateral breast. This is the magnified views showing the same finding. And here is the contrast-enhanced imaging confirming multifocal disease on the right side and the suspicious nodule in the left upper outer quadrant. We did an ultrasound. We were not quite sure if it's exactly the same lesion given this morphology in radial and anteradial fashion. So we decided to do the stereotactic biopsy for this lesion. And it came out as a second focus of disease in the contralateral breast. So there are lots of literature coming supporting the use in the preoperative setting, and here is one of them, in which they found that contrast enhanced was able to detect all the lesions in comparison to MR, who missed at least a case in there. Another case also supportive of the utilization of contrast enhanced by Dr. Fallenberg, in which they noticed that there was no significant size difference for the cancers reported between contrast-enhanced or MRI, and even the final histology. How about the evaluation of additional foci of disease? In this paper, they noticed that the contrast-enhanced had a lower sensitivity comparing MR to contrast-enhanced. So it's a little bit inferior in their case, but I would really like to draw your attention is that we have to be a little bit more critical on how this study was constructed, how MR is also accessible. So this is another thing to think about, but if you're really desperate for it, why not use it? Another example, and this is, I really wanted to show this because this was a work of one of my former trainees. This is a 27-year-old lady referred from Medina, and this is her breast. She was presenting actually with an inflammatory breast cancer of the left side, and so we only imaged the contralateral breast. See how dense is her breast on mammogram, and this is the shown slice from tomosynthesis. So I was really thinking whether there is actually contralateral disease or not, but I couldn't prove it. Then, the second day, I was presented with her outside MRI showing the suspicious non-mass enhancement on the contralateral breast, and this is her contrast-enhanced image. So it's really matching that MRI finding. And I was so happy, actually, at that point, when I called the patient to repeat biopsy, she said, I already did it, but I don't have the pathology submitted. And this was ductal carcinoma in situ of the contralateral disease. So this patient went for bilateral mastectomy. This is an example just to show the extent of microcalcification. I'm not sure if we can see these calcifications. They are fine, linear, in segmental fashion. And here is the proven extent of disease based on CSM. What about lesions characterizations? Here is a case, a young lady going for plastic surgery. She has a mass in the left breast. You can appreciate that the margin is well circumscribed with a clip in it. That's because we biopsied it. And I hope you can appreciate the faint enhancement, but in addition, you can see dark, non-enhancing lines. This was biopsy-proven fibroadenoma, so more or less similar to what we see on MRI to some extent. The tomosynthesis also showed a questionable nodularity, and we did targeted ultrasound to that area, and this is the lesion that we get. So we went in and we vacuumed it, despite the faint uptake on contrast enhanced, and that was an area of sclerosing adenosis. So this is another teaching point, is that maybe contrast enhanced can be a tool to minimize our false positives generated from ultrasound. In general, there is a lot of accuracy and significant improvement in the overall sensitivity of assessment from contrast enhanced. And here is Dr. Hilal's published paper comparing the BIRADS 3 and 4 for MR and contrast enhanced mammography. And they really found that the sensitivity was really high, 95%, specificity is a little bit low, but most important to me is that the negative predictive value is 90 plus, which is doing us a great favor, as I will show in the equivocal finding assessment. What about background parenchymal enhancement? There is, in general, there's agreement between background parenchymal enhancement between MRI and contrast enhanced, and there is usually the same association that we feel. Postmenopausal status, post-radiation changes, it has the same impact on both modalities. Equivocal findings, here is the case presenting initially for the first screening study with the focal asymmetry. contrast enhanced is clearly negative. This is reassuring. So this patient can be reassured that she doesn't have malignancy. This is in contrast to this case, for example, in which we see the highlighted area on the CC view, and ultrasound was negative. So the patient was offered 6-month follow-up with mammogram. And in that time, they had the contrast enhanced installed, and you can see the suspicious enhancement. So they went after it again, and they did biopsy, and it was invasive ductal cancer. Response to neoadjuvant chemotherapy. This is the initial evaluation of this small unifocal disease. This is post-neoadjuvant treatment, where you can barely see any enhancement, and the post-biopsy clip is in the area. Operated breast is a quite challenging case in which we really need to collaborate with our surgeon, medical oncologist, radiation therapist, etc., and the patient herself before. This patient is young. She received neoadjuvant chemotherapy, referred to our center for radiation. She is refusing mastectomy, and examination-wise, she has a typical podorange appearance. So we were in a dilemma. So we asked for the preoperative MR, and this shows this index lesion. This is her preoperative mammogram, and you can see the mass is there in the lower outer quadrant, but this is the post-operative mammogram. It's completely difficult, diffuse skin thickening, a seroma, and we don't know what's left. So this is the contrast-enhanced study showing the seroma in the lower outer quadrant. It's very difficult to project, I'm sorry. But then in there, in the inner aspect, we see an enhancing area. We did an ultrasound. We only saw the seroma and the surgical bed in the lower outer quadrant, but we saw nothing in that area. So we were helpless. We don't see it on ultrasound. Patient doesn't want treatment, but her MR was really ugly. So we really consented the patient. We discussed it with her. We told her we see nothing, but it is suspicious from the beginning. So the patient was convinced to go for treatment. So the teaching point here, she ended up with mastectomy. The teaching point here is that it's really a must to have the preoperative assessment at hand before you can put any recommendations. At the moment, maybe this is the future development for contrast, is that to have a contrast-guided biopsy mechanism. High-risk screening. This is a case of renal failure and chronic liver disease in which the transplant team was really eager to exclude malignancy, and she was on hemodialysis. So they really requested, and they actually favored contrast, iodinated contrast over gadolinium. So we pushed and we did it. Patient was on hemodialysis. So this is the contrast enhanced. It was completely negative, and we cleared the patient for transplant. The negative predictive value of doing mammo to contrast enhanced is much better than the current practice. The radiation dose is not significantly high. It's only 1.2 higher than the dose delivered with the standard mammogram. False positives and false negatives. The most important ones for the false negatives are the ductal carcinoma in situ, tubular cancer, lobular cancer, and this is mainly because of the background parenchymal enhancement. Here is a case that brings up the importance of the 2D imaging, in which this is a patient referred to us with a speculated biopsy-proven cancer. This is the 2D image, and here is the contrast enhanced. There was a subtle faint enhancement in the inner aspect away from the tumor. So we did focused tomosynthesis imaged on that area. Oops. That shows a typical area of architectural distortion and suspicious. So we decided to do a stereotactic biopsy. Yeah, this is the subtle area of distortion seen there. So we did a stereotactic biopsy for it, and it was an additional focus of disease. Now, this was faintly enhancing on contrast. So this teaching point here is that do not eliminate the value of tomo or 2D imaging. The limitations, radiation, of course, lack of descriptors to the moment, learning curve, posterior lesions, breast implants, and lack of biopsy device access. In comparison to MRI, this is just to summarize, the cost of MR is at least 8 times the cost of contrast enhanced. The contrast reaction and allergy is something that we need to take care about for contrast enhanced compared to claustrophobia and pacemaker device for MRI. Examination time is much shorter. The incidence of claustrophobia is not existing for contrast enhanced. But the challenge, we are also lacking the biomedical or biomarker information that is provided by MRI. That's the drawback. For preoperative staging, it is helpful, especially for problem solving or equivocal finding. Preoperative assessment, it's a blessing. For prognostic information, I think MR is much superior and it is proven. Carcinoma of unknown primary, the performance of MRI is way better than contrast enhanced. For the breast implant is a known limitation. So in conclusion, we have witnessed a tremendous development in the field of breast imaging, and this is allowing actually to more tailor, personalized kind of an approach to improve patient care and outcome. But there is a lot of room for improvement, especially with the development of contrast-enhanced tomosynthesis, contrast-enhanced guided biopsy, and I think the one that is more coming or promising is artificial intelligence. Thank you so much.
I would like to present Prof. Jennifer Harvey again. She's from the University of Virginia Health System. She's the chief of the Division of Breast Imaging and the co-director of the UVA Breast Care Program. She's the vice chair of faculty development and the section chief for breast imaging at the American Institute for Radiology Pathology. She serves on or chairs several national committees for the ABR, ACR, and the SBI, and she serves on the editorial board of Radiographics and JACR, and a special consultant to the editor of Radiology. Welcome, Prof. Jennifer.
All right, so I was going to use Socrative software, but if there's no laptop up here, I can't really do that. But that's okay, we're gonna just do it as a quiz then. Okay, so we're gonna skip that part. Okay, so let's talk about breast MRI, and I'm gonna give you some strategies and some cases as examples of how we can approach breast MRI. So for breast foci, you know, one of my friends says, you have to tell me, convince me why you want to biopsy a focus in the breast, because the incidence of cancer is so low. When we're going to worry about a focus is if it is new, if it is, has washout, or if it's in or near a known cancer or a lumpectomy bed. So those are going to be the three things that say I need to biopsy that focus. Again, most foci are benign. As far as masses go, we're going to judge masses first by the shape and margin. If those are suspicious, that's all the information that we need. Besides that, if they have a benign morphology, benign shape, benign margin, that's when we're going to use our kinetics and our other information about enhancement to tell us if somebody needs a biopsy or not. And then non-mass enhancement, we're going to not care as much about the kinetics for non-mass enhancement. We're going to look more at the morphology and the distribution. Okay, so let's do some cases. Okay, can I, by any chance, get the lights down a little bit there? Okay, so in this breast, do you see there's a tiny thing right here? What would we call that? Is that a mass or a focus? Yeah, that's a focus. So the difference between a mass and a focus is this is too small for me to really tell the shape and the margins very well. It's too small to characterize. Okay, good. So that, and then what are the kinetics of this? Yeah, that's blue, so that's persistent, and it's T2 hyperintense. All right, great job. Okay, so what would the BI-RADS be for that? That's a BI-RADS 2, great job. So that has everything about this is saying, I am benign. So this is just a benign focus. We don't need to biopsy that. Even though it's a dominant thing, that's the only focus that's enhancing, that's okay. Everything about that is benign. Okay, here's a high-risk screening, and she also has a focus. Do you see right there? What are the kinetics? It's persistent, great. It is T2 hyperintense. Okay, but now, there's last year. Okay, so what is our BI-RADS now? Yeah, that's a 4 because it's a new focus. So this patient's a high-risk screening. She's getting regular screening MRIs, and she's developed a new focus. So even though most foci are benign, when it's new, just like if you had a little group of round calcifications, right? Most round calcifications in the breast are benign. But if it's a new group, new focus, that gets a biopsy. This is DCIS. Great job. Okay, now this patient has had a prior left breast lumpectomy. That's why it's kind of deformed on that side. And here's a post-surgical clip. So what would your BI-RADS be for this case? Oh, that's fantastic. Thank you. Okay. Okay, so this is my T1 post, and this is the subtraction. So what do you think? BI-RADS 2, 3, or 4? 4, excellent. Okay, so at first you look at this and you're like, oh, maybe that's just, the metal artifact, right? But susceptibility. But susceptibility isn't going to show up on the subtraction, right? If that was just susceptibility artifact, then you would not see enhancement on the subtraction. So this is a little enhancing focus in a lumpectomy bed, so that's a BI-RADS 4. Okay, good. So a dominant focus, most are benign, especially if it's T2 hyperintense and persistent. I don't even put those in my report in those cases. They're just benign little foci. We're going to be worried about a focus if there's washout, if it's new, or if it's near a cancer, or in a lumpectomy bed. So those are the 3 things that are going to tell us, ooh, this focus might not be benign, and we need to biopsy that, okay? All right, so that's foci. Okay, what do you think about this? Okay, the calipers tell us, right? So there's something right there. So here I have a little linear area of non-mass enhancement. So linear distribution, it's pretty homogeneous in its enhancement. And what are the kinetics there? So that's washout, excellent. And then, here's her prior. So what do you think about that? What would your BI-RADS be there? 4, good. Okay, so I have a new area of linear enhancement. The way I think of non-mass enhancement is if those were calcifications in that distribution, would I biopsy that? If those were calcifications, would you biopsy that? Yes, right, because linear distribution. Good, DCIS, nice job. Okay, how about this? Here I have high-risk screening. There's her MIP. There's her T1 post. What would your BI-RADS be here? 4, excellent. Same sort of thing. But what about, there's no washout there. It's not even coloring. Can't I just give that a BI-RADS 2? Okay, you guys attended my last lecture. Nice job. Okay, so with linear non-mass enhancement, we really care more about the distribution of the non-mass enhancement. So linear segmental should always be suspicious. Just remember, if those were calcifications, you would biopsy that. That's at least a BI-RADS 4. We don't care about the kinetics because there may not be enough angiogenesis yet to give us that washout. So DCIS on MRI for non-mass enhancement, we're going to look for a bad distribution. We're going to look for heterogeneous or clumped morphology, but the kinetics don't help us that much. 16% are not going to reach the threshold to have color, and only 5% are going to have washout. So most are going to have a benign kinetic pattern. So that makes these things much more important. So for NME, we want to look mainly at the distribution and the morphology of how that's enhancing. Most important. Okay. So this is a high-risk screening. What is the most likely diagnosis for this patient? Yeah, DCIS. So what's the other cancer that I'm going to worry about for non-mass enhancement? It's invasive lobular carcinoma. But in this segmental distribution, I'm going to be most worried about DCIS. Great. Okay, so this is her MR. What would you recommend? Okay, so when we do this on the quiz, I actually don't have a right answer. Except for I don't do gamma imaging. I used to a long time ago, but the body dose is too high, so I don't do that anymore. So I think that the other three are actually reasonable options. So when we have suspicious non-mass enhancement, the ultrasound is often negative, right? You might be able to find a correlate on ultrasound, but it can be challenging for non-mass enhancement. So often I will go just straight to an MR-guided biopsy in those cases, but this is worth thinking about. So at our place, we alternate mammography and MRI every 6 months for our high-risk patients. So this patient hasn't had a mammogram in 6 months. What am I thinking about here? DCIS. So when this happens, think about getting a mammogram. So here's her mammogram. So it's a little bit hard to see up here, but do you see the fine linear calcifications? There's even some down in here that are harder to see. And then look, this is her prior, really only 6 months earlier, and she's got like maybe 2 calcifications there. But now, how can I do her biopsy? Stereotactic. Who doesn't like a stereotactic biopsy? Like, that's so much better than an MRI-guided biopsy, right? It's like 10 minutes, really quick, so much easier for the patient than going over to MRI and doing an MRI-guided biopsy. So just think about that. If you have a pretty suspicious area of non-mass enhancement, just think about getting a mammogram if they haven't had one for a while. You might be able to identify calcifications that you can target for a subsequent stereotactic biopsy instead of MRI-guided. And not only was that DCIS, there was actually an invasive component too. Okay, what do we think about here? This patient has new DCIS. And what else am I going to be worried about? So what are the findings? So here I have segmental non-mass enhancement in that upper inner quadrant of the right breast. But the other thing that she has is she's got multiple enhancing masses with washout in that same area of non-mass enhancement. So what would I be worried about then? Invasive. So when you have somebody that looks like they have high suspicion for DCIS, go on and look for that invasive component. Okay, and I showed this one in the last session, so everybody should get this right. New right bloody nipple discharge. This is a galactogram. I love doing these. I know people don't. So there's lots of little tiny defects. Do you see that? There's just very irregular parts of her duct. See, like right there. There's lots of intraductal filling defects. So this would be really concerning for DCIS. We biopsied that, and it was. And then here is her MRI. She's got segmental non-mass enhancement, and then, but what's with it? I love this sagittal reconstruction. So nice, enhancing, persistent, clumped, non-mass-like enhancement. So that's her DCIS, but then what is this? That's her invasive component. So what are we gonna do then? Then we gotta go do an ultrasound, find if we can find that invasive component and target that. Okay, but there's another finding. What about that? Does that need a biopsy? Yes. So another area of linear non-mass enhancement. That one was fibrocystic. So not all linear areas of non-mass enhancement are going to be cancer, but they do need a biopsy. Great job. Okay, here's a patient who had prior DCIS on the right, and then she had this as a screening MRI. So which is abnormal, right or left? The right, excellent. Okay, so what do I see here? So here's some clumped non-mass enhancement. What else is there? Yeah, do you see there's a little mass with that? So the non-mass enhancement is blue. Doesn't mean it's not suspicious. That's still concerning because it's linear and clumped. And then she's got this mass with washout here. So what am I worried about now? Yeah, DCIS with invasion. So when you have a local recurrence after DCIS, about half will be invasive. And that's really unfortunate because then their outcome is based on the invasive component. So outcome of DCIS alone is really excellent, but if they develop an invasive component, the outcome is worse because it's based on invasion. Okay, what do you think this finding is? Let me go over this. So here's her 2D mammogram. Here's her group of clustered microcalcifications. So she had a small group. We did a core needle biopsy stereotactic, and it shows DCIS. And here is her staging MRI. So what do you think? What is the finding? Okay. All right, so right in here, this is my T1, here's my sub. So there is linear enhancement here, but it's in the wrong direction, right? You're like, that looks really funny. If it's DCIS, it should be going in a ductal distribution. This is going the opposite direction. And do you see it's even a little bit of enhancement out at her skin? So this is just enhancement of the core needle biopsy track. It's not uncommon at all. It doesn't mean there's anything abnormal there. This is actually kind of hard to tell. Is there even any residual DCIS left? There might be some left. She still needs an excision, right? You can't assume there isn't, but there certainly isn't very much. They need to excise this, but there's probably not very much DCIS left. In fact, there may be none. It's still a BI-RADS 6 because we know that she's had breast cancer at that site, okay? So biopsy tracks can enhance as well as, of course, post-surgical scars too. Okay, what do we think about this one? How would we classify the finding? What is the finding? Clumped, non-mass enhancement, and I would give this a regional enhancement. So even though part of this looks more like a duct, do you see how it's sort of broader in expanse? And clumped, I would call this because, you know, like cottage cheese, it's like little clumps. It looks like that. The more clumpy it is, the more worried you should be about cancer. This could easily be DCIS, but this is actually invasive lobular carcinoma. Invasive lobular can definitely present as non-mass enhancement. Okay, so for non-mass enhancement, when it's cancer, usually DCIS, sometimes invasive lobular carcinoma, we're going to use our morphology of the enhancement as well as the distribution. We don't care about the kinetics as far as assessing non-mass enhancement. It's not very helpful. Okay, what would your BI-RADS be for this case? Okay, so one thing, I never give a BI-RADS 0 for an MRI. Why? Because let's say I said BI-RADS 0, let's do an ultrasound, and then the ultrasound is negative. Your colleagues will not like you because then they have to go back and give a final assessment for the MRI, right? Don't do that to your colleagues. They don't like that. So here it's got to be either what, 2, 3, or 4? What do you think? 2? Who votes 2? You guys are right. Good job. What is this? Fibroadenoma. Excellent. Okay, so what gives this away? Okay, so here's my T1. It's enhancing. And it's got, it does have a tiny bit of mixed kinetics, but it's really mostly benign kinetics. It is T2 hyperintense, but what really helps me is this. This is just sort of a window down T1. So what are those? Yeah, little nice thin non-enhancing septations. So that's BI-RADS 2. So when I see non-enhancing septations, that's got a 98% negative predictive value for cancer. So these are fibroadenomas. You don't need to biopsy those. Nice job. Okay, what's my BI-RADS here? Let's go over the findings. Oval, circumscribed mass, T2 hyperintense with persistent kinetics. Yes, that's Photoshop. Okay, what is my BI-RADS? This is a BI-RADS 2. So here I have a benign shape, oval. I have benign margins, circumscribed, and I have benign kinetics, persistent. All three, and it's T2 hyperintense. So everything about this is benign characteristics. So this is BI-RADS 2. So even on a first mammogram, BI-RADS 2, or first MRI, sorry. Okay, so round and oval circumscribed T2 hyperintense masses with persistent kinetics is BI-RADS 2. You don't need to biopsy those. Okay, what about if it's red? It's washout. 4, good. Okay, washout should always like make you perk up, right? Like, wait, I don't like that. Good. So same thing. Now I have benign shape, right? It's oval, circumscribed, T2 hyperintense, but that washout, that gets a biopsy. So that has bad kinetics. So when you have a mass that has benign shape and margins, you're going to use your kinetics then to tell you if it needs a biopsy. So persistent, BI-RADS 2, washout, BI-RADS 4. Okay? Let's practice that. Okay, so here I have round mass, circumscribed margins with washout. There's last year. What's my BI-RADS? 4, good. First of all, it's new. Anything that's new should make you worried. But even without me giving you the prior, that washout should tell you that that's not happy and that needs a biopsy. This is invasive ductal carcinoma. Great job. Okay, what about this one? Good. Okay, so here I have a mass. It's hard for me to see from this angle. It's got washout. Okay, so what is my BI-RADS? Oh, sorry, it's right there. There, washout. BI-RADS 4. See, you guys are so good at this. Okay. See, MR is easy. Okay, here's a new one. It's the right breast, oval circumscribed, T2 hyperintense, blue. Blue equals BI-RADS 2. Okay, excellent. So BI-RADS 2. Now, what would you do if it was not T2 hyperintense? So if it's sort of in the middle, like it's got one thing missing, so maybe it's not T2 hyperintense, or it's got more plateau instead of persistent, but it doesn't have washout, then I give these a BI-RADS 3. So, because remember, most of these are going to be just little fibroadenomas, maybe a papilloma or something like that, but these are mostly going to be benign masses. So for me, if it's missing one of those things I'm looking for, just one, then I'm going to do a BI-RADS 3. So there's not a lot of literature on this, but that's sort of what a lot of people do. Okay, how about this one? Okay, let's go over the characteristics. Okay, so here I've got a mass in the tail of the breast, kind of heterogeneously enhancing. It's got sort of mixed kinetics. It is not T2 hyperintense, so BI-RADS. Maybe it's just a lymph node. Why don't we just 3 it? Don't do that. All right. Now, I think this is a really hard area because our brain wants to think stuff in the axillary tail is benign, right? It's just a little lymph node. But really, look, if you look, this really is in the breast tissue. It's not high enough out. And triple-negative cancers particularly have a preponderance to occur in the posterior breast. And so just make sure your brain doesn't automatically think everything in that lateral sort of tail of the breast is just a lymph node. You got to really look closely at it. If you look, it's more heterogeneous enhancement, and the margins to me are kind of indistinct. So this is a high-grade invasive ductal carcinoma. Great job. Okay, so as far as masses go, so we're going to look for that irregular shape or margins. If those are suspicious, you don't need to know anything else. We don't care about the kinetics then. We don't care about the T2. So shape and margins are the most important things to look at for a mass. If the mass has a benign shape and margin, meaning it's round or oval with a circumscribed margin, that's when we need to use that other information to help us make decisions. So that's when we need to know the kinetics and the T2 and the internal enhancement pattern to help us know, does that need a biopsy or not? Okay, so let me just summarize then. So most foci are benign. Like I told you, my friend said, like, convince me why you want to biopsy a focus, because most are benign. When are we going to worry about a focus? New, washout, and cancer. Yeah, if it's in a cancer breast, be worried. Even if it's a lumpectomy breast, be worried about those. Good. Okay, non-mass enhancement. We're going to judge that on our distribution and the enhancement patterns. So clumped, clustered ring, those are going to be the most concerning. Do we care about kinetics? No, kinetics do not help us with the assessment of non-mass enhancement. Great job. Okay, and then when you have NME, you can go ahead and just go straight to MR-guided biopsy, but if it's been a while, think about getting a mammogram, maybe some magnification views of that area, because you might find calcifications that will help you do a stereotactic biopsy instead of an MR-guided biopsy, and who doesn't like that better? Okay, and then when we have a round or oval circumscribed mass, that's when we're going to use our kinetics. The other times it's not as helpful. All right, thank you so much.
Thank you, Dr. Harvey, for the great presentation, awesome as usual. With a great honor, I would like to introduce Dr. Laila Al-Ashkar, Associate Professor, Consultant Radiologist at the Breast Imaging Unit of King Abdulaziz University Hospital in Jeddah. Dr. Laila graduated and obtained her master's degree from King Abdulaziz University. Then in Canada, she completed her residency training program at McGill University and pursued a body MRI fellowship. After, she did another fellowship, breast imaging fellowship from the University of British Columbia, Vancouver. Her vast experience in the field of breast imaging and as an excellent speaker in many local and international conferences. We are excited to hear her talk today about the update in breast imaging. Please welcome Dr. Laila Ashkar.
Thank you very much for the great introduction, and I thank the Society for inviting us, especially all the distinguished speakers, including our teachers. I graduated from the medical school here, and we have had great influence and role models. So today I will be talking about updates in breast imaging. And I didn't know what to include because many of the speakers already covered most of those topics, but I'll just go over them briefly. So I wanted to give you a bit of an idea about the breast density legislation. I will talk briefly about tomosynthesis, screening breast ultrasound, contrast-enhanced mammography that was covered by Dr. Humayes, abbreviated MRI, molecular breast imaging, which will be covered by Dr. Najla as well, so I will skip over that, and a few slides about image-guided ablation of breast lesions, like Dr. Boris touched upon, and a few words about radiogenomics and artificial intelligence in breast imaging. Okay. So RU-Dense is a grassroots movement that was initiated in the US by a lady. Her name is Nancy Capella, and she is someone who had a mammogram and was diagnosed with breast cancer 2 months later. So she was really frustrated, and she initiated this whole movement about the right of patients to know about their breast density. And it is her mission that physicians need to inform their patients about their breast density because 40% of women, they have a 48% chance of having breast cancer with dense breasts. And that's the lady, Nancy Capello, and we owe her this initiative. Her mission is to inform patients that dense breast tissue is an independent risk factor for breast cancer, and they are 5 times more likely to have breast cancer. And supplemental screening was introduced after this, and most of the time ultrasound is the supplemental screening tool for now, in addition to other modalities, which I will discuss. And ultrasound increased the detection of breast cancer from 48% to 97% for women with dense breasts. And after this movement, the publications showed that around more than 764,000 women that are above 40 years old had dense breasts. And in the US alone, 27 million women aged 40 or above have dense breasts, which are around 43% of the population. So after this movement, insurance included covering supplemental screening ultrasound for women with dense breasts. And since then, density reporting is mandatory in many states in the US, and more to come. And this gave rise to a few questions, and these include: how should density be measured? Do all women with dense breasts need supplemental screening? And which modality do we use for supplemental screening? And is it cost effective? Which ones are cost effective, and are they cost effective or not? And what is the effect of supplemental screening? So supplementals, there are some softwares that have been introduced in the market to measure these densities, and these are some vendors. And a lot of institutes have purchased them, especially in the States. Supplemental screening modalities include tomosynthesis, screening breast ultrasound, contrast-enhanced mammography, MRI, especially abbreviated MRI, and molecular breast imaging. These are a few trials that show that increase in cancer detection has been accomplished by adding supplemental screening, 24% by ultrasound, and 56% increase in cancer detection rate by MRI in patients with dense breast. This is a slide that shows the cancer yield with different modalities. Oops. And mammogram alone has a cancer yield of 5%, ultrasound 6%, mammogram with ultrasound 7%, and then when you introduce MRI alone has a cancer yield of 14%, and if mammogram is added prior to that, it's almost similar, as well as ultrasound. There are some drawbacks to mammography, and this includes the camouflage effect, which misses cancer in 30%, and the high recall rate. And that's why the other supplemental screening tools have been added. And of course, this resulted in increasing cost and more anxiety to the patients. So tomosynthesis, Dr. Noha has already touched upon it, and the concept of tomosynthesis is to spread the overlapping breast tissue by taking angled conventional 2D imaging, which separate the overlapping tissue. And most of us all are familiar with tomosynthesis. I'm not going to go through the details, so that's how it looks like. The arc of movement of the X-ray source, and then the detector detects the images, and these multiple low projections are performed with the machine, and there are different vendors. It takes almost 4 seconds or less. And this is an example of an image. Of course, tomosynthesis is amazing in showing architectural distortion, and this is just an example of a 2D mammogram in comparison to an image from a 3D tomosynthesis. Tomosynthesis has decreased the recall rate. However, at present, there's insufficient evidence to justify to change from standard digital mammography to 3D imaging for screening, although some centers in the US have already done that. Currently here in Saudi Arabia, most of the institutes are using tomosynthesis for diagnosis at this time. This brings us to a little summary on 2D synthesized image, which is reconstructed from 3D data set, and all the tomo info is gathered in one 2D synthesized view, and a few vendors, some call it C view, some call it S view. There's no additional radiation involved, and this has been approved for Hologic in 2013 by the FDA. And in some centers, this C-view has replaced the conventional 2D imaging, especially in the screening setting. This is just an example of a 2D image mammogram, and then comparing it to the C-view, as well as one of the tomosynthesis slices. As you can see, these are almost all comparable. And this is just something to show in the literature that 2-view combination of 2D view plus tomo should be considered acceptable for use in mammographic screening. Of course, anybody who has a tomosynthesis capability should also be, this is just to point out that tomo biopsy is something that needs to be implemented if you have a tomo machine, and otherwise it is difficult to start a service with 3D imaging if you don't have the biopsy capability. And as Dr. Noha mentioned, there are some drawbacks for tomo, which includes radiation dose, some motion artifacts from scanning time, the amount of data that needs to be saved in the server, and being able to biopsy lesions. However, tomosynthesis decreases the recall rate and is mainly used in the diagnostic setting at this time. I'm going to talk a little bit about screening breast ultrasound, although Dr. Boris has already touched upon it. It's a very popular supplemental screening tool because it does not involve any radiation, it's non-invasive, it's readily available, and it's inexpensive. And there are the whole breast ultrasound shows us a cancer yield of about 3 to 4% per thousand of patients, and usually these are small and node negative. This is the Akron trial, and it has been shown that the average time to perform bilateral ultrasound is 19 minutes. This is an example of an automated breast ultrasound. I'll just skip through these quickly. As Dr. Boris has shown, this is the large transducer. This is performed by the breast technologist, and the patient has to wear a little shirt, and then you take quadrants, images of quadrants, and these are reconstructed with different planes. And this is an image showing the AP medial and lateral views of the left breast. And then these are correlated in a multiplanar fashion. And this, for example, demonstrates a lesion which was diagnosed as breast cancer. So supplemental screening with breast ultrasound can be performed by a handheld unit as well as an automated ultrasound unit. And these are the pros and cons for both. As you can see, they're quite similar in time. However, the training for handheld needs to be established, and it takes longer time than the ones that are automated. And the number of images are quite large for automated breast ultrasound, which takes time to interpret. So some radiologists are not fond of the time it takes to read those. There are some future directions in screening breast ultrasound, including artificial intelligence, which is coming up and which will take off the workload, as well as decrease the timing for reading those images. Abbreviated breast MRI has come up in the literature, especially by the pioneer, Dr. Kuhl, who showed that it is a novel approach for breast cancer screening, and she advocated that instead of doing the whole, the multiple sequences to diagnose breast cancer, we only would need a pre-contrast T1 image, a post-contrast, and a subtracted image, and then one MIP image. And she advocated that this would be taken in about 3 minutes. The patient only needs to be in the scanner for 3 minutes, and supposedly these are read in 3 seconds. So this is low cost, and it takes less than 10 minutes, And it was shown that the cancer detection rate was increased by 150%. So it was suggested that it may turn into the optimal screening tool in 1 to 3 years from now. Again, these are a few papers on that, and again, this diagram shows that the cancer yield of MRI alone is almost 15% compared to 5% for mammography, which is the current screening tool. Molecular imaging will be covered by Dr. Najla, so I will not talk about it at this time. And then, these are a few points that I would like you to take home. That for all women with dense breast, tomosynthesis is the supplemental screening tool at this time, in addition to screening ultrasound. For intermediate and high-risk patients, screening ultrasound and abbreviated MRI are very reasonable, and elastography with ultrasound can also help in that. A few words on image-guided ablation of breast lesions. Ablation at this time of breast cancer is still an investigational and off-label use. And it mostly is used at early stage for less than 2 centimeters small cancers, and for women that are above 50 years of age. And these are usually done under ultrasound and MRI guidance. And the best studied techniques at this time are radiofrequency ablation, cryoablation, and high-intensity focused ultrasound ablation. This is a targeted therapy, and compared to surgery, this is less invasive, it costs less, the patient goes through fast recovery, and there's acceptable cosmesis and patient satisfaction, and there are fewer complications. This is one of the landmark papers talking about image-guided tumor ablation. There are 2 types, thermal and non-thermal. For the thermal, there is the cryoablation, radiofrequency, laser ablation, microwave ablation, and the HIFU. So this is just an image illustrating the ultrasound-guided cryoablation, which at this time is commercially available for fibroadenomas, and that is FDA approved. And for breast cancer, it is still investigational. And the concept is that cryoablation freezes and destroys the cells by mechanically destructing them. And osmosis shifts the fluid outside the cells and causes vascular thrombosis, and the macrophages absorb the necrotic debris. And this is just an illustration of one of the vendors with the cryo probe that shows the area that freezes the target. The freezing zone is usually around 4 to 5 centimeters around the tip of the probe. And this is an example of a procedure. It's done under ultrasound guidance. The temperature is less than 20 degrees, and it takes about 6 to 10 minutes per cycle, and it depends on the size of the tumor as well. High-intensity focused ultrasound is non-invasive, and you can do it through the intact skin, and it is done under MR or ultrasound guidance. And as you can, with MRI, it's incorporated into the machine, and the patient needs to be prone and with the breast in water, and then the pulses are released, each about 10 to 30 seconds long, and the ablation rates range from 24 to 100% with temperature monitoring, which is really important. This is ultrasound-guided HIFU for fibroadenomas is commercially available, especially in Europe. And I mean, we can talk to our colleagues to know more about it. This is and also done under MRI guidance, which is more cumbersome and a more novel technology. This is just a comparison between the hyperthermic and the cryoablation. Hyperthermic HIFU is more painful because it is related to heat, and sometimes skin burns can occur. And the temperature needs to be monitored, which is very crucial. This is just a take-home message that image-guided breast ablation has advantages and disadvantages, and it needs some operator skills which need to be learned. And if it will replace lumpectomy at one point in time, we're not sure yet, but this, we will watch that. Lastly, a few words have been mentioned about radiogenomics. Radiogenomics in breast cancer allows for focused disease treatment and prevention strategies according to the patient's or their disease's genetic makeup. So it aims to correlate the imaging phenotypes from different modalities with the underlying genes and mutations and the expression patterns of the patient's tumors. It's currently focusing more on the dynamic contrast-enhanced MRI images. However, like Dr. Boris has mentioned, elastography is playing in there as well, and this needs to be studied more. So precision medicine and personalized medicine in breast cancer is really important, and the goal is to develop imaging biomarkers that can predict the risk and the outcomes of therapy. And this is one of the papers that discusses this, so I think we need to pay attention in the future that this will be coming up. Lastly, artificial intelligence in breast imaging is very popular. It's a hot topic these days. It's a deep learning system, and it works by mining vast amounts of data to find subtle patterns beyond human recognition. So the AI system is trained on large imaging data sets from different modalities to identify suspicious findings, and eventually this AI system can pick up different patterns in on different imaging sets and read those with significant accuracy. There are high expectations that the AI might avoid missed cancers and false positives, which have been resulting in overdiagnosis and potential overtreatment, and AI should help us tackle this. However, AI is not there yet in terms of diagnosing patients and solely. A radiologist is still always necessary. For now, AI helps us in controlling workflow, decreasing our time of readings, and it helps improve outcome analysis. Yet, AI cannot be relied on or responsible for physicians' decisions that may affect survival. So we should not be scared that it will replace us at one point in time. It's not time yet. But however, we need to educate ourselves in artificial intelligence to keep up with the evolving technology. A lot of papers have come out, and for now, artificial intelligence is pioneering. Data sets have been entered from mammography studies. Ultrasound and Tomo AI will also be coming up soon. In conclusion, proper validation and large prospective studies need to be performed to establish evidence-based artificial intelligence models. Algorithms should be expanded to cover other fields of breast imaging, like I've mentioned, Tomo, MRI, and automated 3D ultrasounds. And future research in the accessibility of using AI in breast cancer screening and the many ethical and social and legal implications need to be studied. Thank you very much.
On behalf of the Radiological Society of Saudi Arabia, we would like to thank Dr. Layla Ashkar for the awesome presentation and collaboration to this successful event. Thank you, Dr. Layla.
Thank you.
Another small token of appreciation, sorry. Another small token of appreciation for Prof. Sami Al-Amoudi. And for Dr. Noha Khamis.
Dr. Noha also conducted yesterday a very successful hand-on workshop, and today her awesome speech.